They aren't listening to us. Okay, I'm terribly sorry. Welcome to Rounds. This is a 9-year-old Labrador spayed female with a 1-year history of hemorrhagic bowel movements and basically glaucoma in this eye. Terribly sorry about all that. There was an extensive workup that included many things. The only remarkable finding was hyperglobulinemia. And they actually also did a rectal scrape that was unremarkable. But they were thinking correctly in this case. So back to the globe. Okay, sorry about that, everyone. All right. So here's the globe hemisected. The cornea is always at the top. It's a little bit cloudy. That is corneal edema. Here we have the iris, and you can see how the iris kind of around the pupil kind of bows backwards and kind of sticks to the lens. So that's that posterior synechia with iris bombay. The lens is a little bit cloudy. And most prominently, there is hemorrhage in the posterior chamber, in the vitreal space, and also the subretinal space. This is our detached retina that is slightly thickened. And there's a bit of a tan band of stuff on the exposed choroid. So those are our major gross findings. All right, here's our subgross. So here's the cornea. I like to put it on the left. Here's the iris heading back toward the lens. So that's indicative of our posterior synechia with iris bombay. The lens itself is actually kind of boring at this magnification, at least. And you can see all that bright red is our hemorrhage. Here is the posterior chamber behind the iris and the ciliary body, or next to the ciliary body. As we move backward, here's our detached retina, and there's subretinal hemorrhage, and there's hemorrhage in the vitreal space as well. So let's go ahead and jump. Hi, Meg. So the anterior segment is kind of boring. The cornea is there's a little bit of vascularization in the peripheral corneal stroma here, and you can see some hemorrhage in the anterior chamber. As we move back, we're going to spend not very much time on the anterior segment because all the fun stuff is happening in the back here. So here's the retina. Here's the retina proper. And then there's all this extra stuff that's adhering to the underside of the retina, the outer surface of the retina. And then when we move back, there's material adhered to the choroid as well. When you look at this stuff, there is some little basophilic purpley dots in there, which are probably some nuclei of cells. But a lot of it is this sort of almost gray looking, pale purple, maybe pale brown looking material. And when we get higher mag, it's a lot of sort of maybe amorphous looking stuff at slightly lower mag. But when we get higher mag, we start to pick up all of these structures that maybe have some refractile properties. And let's see here. A lot of these cells, these guys are very large with abundant cytoplasm. These are macrophages. And then there are some neutrophils around. It's probably a neutrophil. It's probably a neutrophil. You can see the red blood cells around. So that's our hemorrhage. But what we have is myriad organisms that are not really, they don't look like yeast. And they have these sort of folded cellular walls. And so this is actually an algae of some sort. I don't actually know what kind of algae. One of the more common forms that can lead to systemic infections is Prototheca, which is an achlorophyllous algae, so it does not produce chlorophyll. And there are other varieties that also can lack chlorophyll. I'm blanking on the name of one of the others at the moment. But anyway, So if I scan around for a long time, which I'm not going to do right now, we might be able to find one that's actually exhibiting endosporulation. However, when I wrote this case, I did not take the time to do that, and I'm not going to do it now. Here are some organisms where you can actually see a little bit of a nucleus of some sort, and that might not be the correct term for this this species of creature. I don't know. Here's one that several organisms that might be inside of a macrophage, so there's some phagocytosis going on. But one of the more striking features about this condition in general, in the eye in particular, is that the number of organisms far outweighs the number of inflammatory cells. So we will often refer to this as a paucicellular endophthalmitis because, as I said, the number of inflammatory cells is much lower than the actual number of organisms. So my assumption is that this is Prototheca, but there's no way to speciate it via histology, so I really have no idea what it actually is.
Thinking about chlorella?
Yeah, chlorella, thank you. I can remember the name.
Yeah,
Right,
it
there-
has chlorophyll.
There are versions of it that don't have it, right?
Yeah, but they're usually, well, I haven't seen that many with brown. They have a brown cast too.
Ah, okay, all right.
They also have a pretty prominent Y shape in the middle of the chlorella.
Oh, okay,
So they're discorrelating, it's, yeah.
okay.
I'm going to repeat that. Get him.
Sorry.
So chlorella, which can also lack chlorophyll, tends to be a little bit more brownish, according to Dr. Gasper here in the audience. And also there's a Y-shaped thing in them.
Mercedes-Benz.
So
I think either endosporulate as a formula or Mercedes-Benz though. So
yeah.
But that's more characters. Anyway, I'll stop talking because you can't hear.
That's okay. Anyway, so we're arguing about what this possibly could be. My assumption is that this is probably Prototheca, but honestly, there are probably many others out there that have never been speciated that lead to systemic disease like this. Anyway, as far as the retina goes, it is chronically detached and it's lacking its normal layering. So we have retinal atrophy. And in some areas, it sort of disappears, and this is consistent with retinal necrosis. Which probably is due to the inflammation and such. And those are the main features of this eye. As I said, there was,
How old was the hemorrhagic?
1 year.
Wow.
Yeah. So animals will typically pick it up from drinking contaminated water. And so it usually sets up shop in the intestines first, and then will disseminate from there. So it will often cause hemorrhagic diarrhea. And one of the more reliable ways of trying to diagnose it, at least, is doing a rectal scrape, and you look for the organisms on the rectal scrape, which they had done in this patient and didn't find anything, sadly. The other sad thing is that Prototheca does not really respond to any kind of therapy. So sadly, that I'm aware of at least, I think they'll try various things, but ultimately algae is not susceptible to antifungal drugs or antibiotics or anything like that. So I don't know, they might be able to treat symptomatically for a while, but sadly, it tends to lead to the death of the animal. I've never seen it in a cat, only in dogs, but I think other, I'm sure ruminants can get it occasionally. I remember a distinct article from when I was studying for board about chlorella-induced mastitis in a cow, which may have been a more direct inoculation as opposed to systemic. But anyway, so that's this case.
So we have an update here from Taylor. I think it was her case. It said the patient presented for suture removal 12 days later. And the left eye had developed complete retinal detachment with significant subretinal infiltrate by the time it came back. So it came bilateral.
Okay. So these are some abbreviated diagnoses. So I just summarized the history that we got. And in the right globe, granulomatous endophthalmitis with abundant algal organisms suggestive of Prototheca species, moderate to marked intraocular hemorrhage and glaucoma as per history. When the retina is detached and atrophied due to detachment, it's difficult to confirm glaucomatous degeneration, but there was certainly reason for it with the posterior synechia. So, all right. Next up, this is a dog named, no, never mind, I'm not going to say her name. This is a 9-year-old spayed female mixed breed dog. She was in a rescue situation, so I don't know how she ended up in the rescue situation, but she's probably a little pity mix of some sort. And the history we got was severe conjunctival swelling / modeling / overgrowth, bilateral, entropion of both eyes, so eyelid entropion of both eyes, corneal edema in both eyes, dazzle response positive, meaning she could see something, but otherwise functionally blind. Stray dog found tied to a tree. No response to cyclosporin, erythromycin, or ofloxacin. And she was heartworm positive. So they submitted both eyes and all adnexa, including, so that means the eyelids and third eyelids and such. And we did not take a gross photo of them, but I think the clinical picture is pretty dramatic. So you can see all of this bright red tissue is that proliferative conjunctival tissue. And maybe you can see some corneal surface here. It's a little hard to say. I can't really see it in her left eye. That is what this dog looked like clinically. First, I will show a section of eyelid. And this is really pretty dramatic. So let's see if I can get us oriented a bit here. So here's some hair follicles and some adnexal glands, so sebaceous glands and such, apricot glands. So this is the haired skin of the eyelid. And as we come around to the conjunctival side, you can appreciate that there's this really dramatic process happening. And at first you look at this and you think, my gosh, if you just had been handed this slide and didn't know anything else about the case, you might think, wow, could this be some sort of neoplasm, some sort of tumor? But knowing that it's bilateral, and then when you get closer, so it'd be a little bit unusual to have bilateral neoplasia like this, that's so bilaterally symmetric. But as we get closer, what we have is epithelium on the surface, and then we have all of these epithelial-lined cavities or cystic spaces. And a lot of those cystic spaces contain some eosinophilic material, some probably secretory material, and here's one with a few neutrophils in it. So there's a little bit of inflammation in the lumens of these things. And then also we have a bunch of goblet cells. So this is a goblet cell that's producing mucin or mucus. And that's partly what we're seeing in the lumen here is the mucus. The stroma itself is heavily infiltrated by numerous inflammatory cells. So we have a lot of plasma cells. Here's some plasma cells, some lymphocytes. And if we scan around, we will pick up some eosinophils. Here's one right here. So here's an eosinophil. They were kind of a minor component of the inflammation, but they were definitely present all over the place. And there are some macrophages as well. And let me see if we can find a spot. Some of the macrophages contain some, I think it's in the other slide, so I'll switch to the other slide. Some of the macrophages that are in the stroma contain some very pale, kind of brownish material, which is probably, oh, here we go. There's a beautiful example of what I'm looking at, or what I was trying to find. This is not pale. This is more obvious. Material here, which is some gamish of phagocytose, probably secretory material that has been leaking out of these cystic spaces into the stroma. So this is, I'll show you the globe now. And as I said, we got both globes and both eyelids and everything, or eyelids from both eyes. Here.
So that was palpebral conj?
Yeah, that was palpebral conjunctiva of the eyelids. So here we have the actual globe. So there's an iris leaflet. Oh gosh, out of focus, Gillian. Here's an iris leaflet. So we're in the cornea here. Here's the bulbar conjunctival tissue here. The cornea itself is actually not as affected. This is like a little papilliferous kind of frond coming from this proliferative bulbar conjunctiva. The corneal epithelium is hyperplastic for sure, but it's not as hyperplastic as the conjunctival epithelium is. So you can see how thickened this is, and it has this undulating contour with the anterior corneal stroma. And there is a keratitis, so there is inflammation in the corneal stroma. The corneal stroma is also vascularized. You can see all these blood vessels here. And then if you look at the organization of the corneal stromal lamellae here and compare that to here, you can see how coarse the collagen bundles here and how a little bit less organized they are. So this is fibrosis, or at least what we call fibrosis in the cornea. And then once again, the bulbar conj is just so dramatically thickened and greatly expanded by this weird proliferative cystic process with more of that secretory material everywhere. So as I said, this is not neoplastic. The fact that it's bilateral and it has this degree of inflammation, and the cells themselves are pretty bland. And also they're not really infiltrative. I think what we have is more of an exophytic growth of tissue as opposed to invasive growth of these cystic spaces. At least that's the way I interpreted it. So that is the histologic picture. So this was just a weird case, and I don't have a great perfect diagnosis, like slam dunk diagnosis for it, so it's pretty wordy, but severe proliferative eosinophilic lymphoplasmacytic and histiocytic conjunctivitis with cystic hyperplasia and numerous inclusion cysts and mild substantia propria edema. And then there was the corneal changes as well, and pretty much everything else about the globes were normal. So given the eosinophilic component of the inflammation, I suspect that this is some sort of very chronic hypersensitivity reaction, so some sort of allergy or something like that. We had somebody post something to our Pathology nerd listserv recently. Listserv. There isn't really a listserv, but an email list of a very similar thing. I feel like that dog was from Brazil, so there was some question because we're not as familiar. Gillian is not as familiar with Brazilian diseases, but other people chimed in and said, "Yeah." Well, I think Leandro chimed in, and I think it was Ingy anyway, so she would have been familiar with them anyway. So there's no slam dunk diagnosis here. This is very unusual, but it has been documented. And somebody, I think this is similar to what somebody presented in the very first COPS, which was like a vernal conjunctivitis, which is like an allergic kind of conjunctivitis. This was a rescue dog, so we don't know how long it had been going on, but it wasn't responding to any of the drugs that they had tried. They tried cyclosporin. They don't say that they tried steroids, at least, and I don't know how complete of a history we have here. So it's possible that steroids may have helped in this situation to sort of calm everything down. But once it gets to that stage, I don't know how you get rid of cystic hyperplasia like that. You'd have to cut it all out.
Yeah. Some people will call that adenomatous hyperplasia or cystic hyperplasia. Both fit. But I agree with Gillian. I think the main point of the histology is recognizing that that's not a tumor, because it can be very, very impressive. And vernal conjunctivitis is related to, allergic reaction and vernal from, stage of the year from season allergies, theoretically related to season allergies. That's recognizing humans. And they do have a more like cobblestone kind of proliferative appearance to their conjunctiva, but that's, chronic allergies. So you just open a can of worm here. Everyone wants to be a part of the email list for pathology, ocular pathology nerds.
But sorry, I backtracked. We don't actually have an email list. It's when one of us says, "Gosh, what do a few other people think of this?" And then we send an email to.
I know how that started. There
some
was
subset of people.
There was an email about COPS once, I think, or Scoop, and then someone used that same email to ask a question.
Oh yeah. Okay.
And then people kept replying to that same email, and they became a non-official channel for asking questions about ocular case. But that's not a bad idea, creating an actual thing.
You're right. We probably just opened.
Anyone out there willing to host something like that? I don't have the time, but let's keep.
Yeah, we can think about that. Yeah. Anyway, so that's all that I have. So someone else is up next.
So something caustic in the eyes wasn't discussed as a chronic reaction. Doesn't sound like it has ear problems. Doesn't sound like it has paw pad problems.
Correct. I mean, she obviously had some dermal issues.
Yeah, and they were chronic and scarring, so that whatever was historical.
Yeah.
But that would have healed this necessary. That wouldn't necessarily have done that if there was something sprayed into its face.
We do
Bad
have a couple.
dog, here's bear spray. I
Oh,
don't know.
interesting. Oh man, I hope bear spray wouldn't
Anyway.
do that. We definitely have
But I
some
mean-
cases of either acid or base, like injuries to the ocular surface, and they do differ between each other vastly. But maybe in like a chronic healed state, maybe, and but even that, this would be really. I think I'm trying to remember what. I think bases might lead to more of like a conjunctivalization of the corneal surface, and you might end up with a few inclusion cysts because of that, but nothing like this. But that's one thing to keep in mind, I guess, especially with a stray dog that may have been abused. So, yeah. All right. Awesome.
All right, cool.
It doesn't look that much better.
All right, so I'm Jamie Miller. I'm up next here with a couple cases for you. This is a 3-year-old female spayed domestic long-haired cat. We have the right eye, and it comes with a history of adopted with an abnormal non-functional eye with chronic discharge. They said the right eye was phthisical, had entropion in mucoid to mucopurulent discharge. No normal cornea or intraocular structures were appreciated. The left eye was normal. And I've got some surgical pictures, I think. There we go. So after they took out this lovely globe here, here is the phthisical globe. And then we have this like orange tan brown tissue that protrudes from the front, through the front of the globe. It's very shiny.
I love ventricle.
It's the globe
Yeah,
ventricle,
right.
the left
Looks like a
ventricle.
heart.
It does look a little bit like a heart. Yes, so they had suspected that there was complete prolapse of the uveal tract through a corneal perforation. And then here is a hemisection view of our globe. It's a little bit tilted a little bit. So the posterior portion of the globe is back here. It's very wrinkled and very small, so consistent with Phthisis bulbi. And then here is probably our limbus here, a little bit of conj. And then you can see that orange tissue protruding out through the cornea here. So let's take a look at this. All right. See if I can. It's a very small phthisical globe, so let me see if I can get a little bit better orientation. Here's about what it was on the gross picture. So again, here is our wrinkled posterior sclera here. This is all choroid. That's all wrinkled up here in the back with the nice big blood vessels. Here's some ciliary bodies, and so we're at the limbus here. Teeny tiny bit of cornea on either side, which I will show you a little bit closer and prove that to you. And then all of this uveal tissue is extending out through the cornea. And then this is our detached retina here, kind of floating in the back. And something that I didn't point out in the gross photo, there is a lack of lens. So the lens is not here anymore. All right, let's see if we can come around here. All right, so limbus here. So we've got our scleral collagen, a little bit of corneal collagen here, and then it just stops. We've got conjunctiva here, and we've got some symblepharons where the corneal conjunctival epithelium are kind of blending together. And if we get a little bit closer.
How comfortable that iris.
Yeah.
Totally integrated.
Here is what is left of a little bit of descemetous membrane here, nice and wrinkled. And then, yeah, we have our corneal collagen that just kind of stops, and the iris just kind of comes out. And then we've got conjunctiva epithelium come along here. Here's the goblet cells. And we can just follow it along lower here. You can see it just keeps going. There's a little bit of lymphoplasmacytic inflammation in here, some edema, but the conjunctiva.
That's anterior uveitis.
This is, even though, yes, it is now outside the globe, it's still.
Sorry, guys, I'll stop.
Yes, so, and it keeps going and going and going. And as we come back around to the other side here, again, a little bit of corneal stroma here with our prolapsed uvea, pretty much. Here is our detached and very atrophied and gliotic retina. Have the wrinkled tapetum here and choroid. And aside from the little bit of inflammation in that anterior uvea, there's not much inflammation left or present in the globe at all. We also did not sample optic nerve or optic nerve head, but I'm sure it's back there somewhere. All right. So that's basically the really cool, awesome findings for this case. And so these findings here, what we propose is that, there's probably very early like viral infection leading to corneal necrosis and eventual perforation here. And then we've got prolapse of the uvea extending out. The lens is absent, so that was probably extruded at one point previously. And we've got the symblepharon here, which is another non-specific changing, but we often see it with viral infection. So could be herpes virus infection, which is really common. We've also got some cases where the cats were herpes virus negative, but calicivirus positive. So just a different kind of virus. And so all of these lesions put together are consistent with an early life eye disease or early life ocular disease there.
Yeah, so the main points is, and the impressive points is the fact that there's not a lot of reaction to it. These eyes can be very comfortable. Animals they're usually very young, of course, because that happens. What we think happens is that infection possibly happens in utero or around the time the animal is a term, and there is a necrotizing keratitis, or basically straight up corneal necrosis. Then the iris prolapses. Then, since the eyelids are closed, there's time for the epithelium to grow over that prolapsed iris and remodel that whole surface, because that's basically a remodeled surface. The iris, I was jokingly saying, it looked very comfortable there, but it does, right? The epithelium grows over it. There's minimal inflammation. There's minimal intraocular inflammation. And we know there was a perforation because the lens is gone. So the lens was extruded at some point. And there's no signs of a secondary infection, even with that completely replaced cornea. So we have seen cases where these animals are 1, 2, 3 years of age, even more so, and they have that horrible looking eye with a protruding iris, but they look very stable. We've been trying to work some cases to answer that question about a potential herpes infection or a calicivirus infection. But these are, even though the animal is just born and they are relatively chronic, right? The cornea is all gone. So see where we get with that, but hopefully we might get some PCR positivity in some of those cases. Keep you guys posted.
Fish on it.
Was that?
Fish.
Yeah, fish, and yeah, we've been thinking about creative ways of doing that.
Cool.
You could probably call it a rostral uveitis at that
Yeah,
point.
rostral
Here.
Extraocular uveitis. Oh, it's not extraocular; it's still contained.
Much more than anterior.
Yeah. All right. Next up is the left eye from a 15-year-old male neutered Pekingese dog with a very straightforward history of a previous descemetocele over the weekend that ruptured. It'd been apparently going on for 1 to 2 weeks. And the other eye, they noted some corneal mineral and some mild KCS. The dog also has a heart murmur. So here is our heavy section of the globe with the cornea at the top, and we can see this defect here, full thickness through the cornea that's plugged up with some tan material. We've got our iris leaflets that are leading up to it and even prolapsing a little bit through that corneal defect. Our lens is here and was subluxated. The vitreous was a little bit thin. The retina is a little wrinkled. And the odd thing back here, we've got optic nerve here. When I cut this globe, for whatever reason, I ended up splitting the optic nerve. Sometimes it happens. And it was a very weird position because it kind of looks like it's inside the sclera. And so that was a little odd to see grossly, but I do have an explanation for that histologically that I will show you guys. So let's take a look here. All right. So cornea here on the left, we can see our full thickness defect filled with a bunch of fibrin. We've got our iris leaflets again prolapsing in there, trying to plug it all up. A little bit of keratitis and some wrinkling to the back of the globe. And then here is our optic nerve. Again, kind of has the appearance of being inside the sclera, but we can see that there's a lot of dark pink tincture going on here. And we'll take a little bit closer look at that just to show you what's going on there. All right, so much more cornea still present in this case than the last one, but we do see that it does come to an end here. And we've got a little bit of descemetous membrane kind of floating here in our defect. So if we get a little bit closer, we can see lots of blood vessels coming in, neutrophils heading in there as well. Our epithelium is a little bit hyperplastic and adenomatous. We've got these nice little vacuoles in here. And as we approach the defect margin here, this is where we would be looking for evidence of collagenylysis or corneal stromal malacia. Normally that would look like the epithelial cells would be kind of falling into the lytic stroma underneath. That's our histologic evidence of it. We don't always see it, and we didn't find it in this case. But just because we don't see it histologically doesn't mean it wasn't playing a role in the corneal disease. And so sometimes we'll rely on the clinical picture for that. If they say there was malacia clinically, that's a better way of finding it. So, and then again, here is our descemetous membrane. It's coming out. It's extending past where the corneal stroma ends, and it's covered with a bunch of fibrin and neutrophils and hemorrhage. When we have these sort of naked edges of descemetous membrane, sometimes either still attached to or free-floating in our defect, we often associate that with a ruptured descemetocele, which is what they described clinically. So here's the other end here is kind of whipping out here into the defect. The other thing on this side is we have reepithelialization. So our corneal epithelium is coming along, and then it's turning around the corner and growing along over our exposed corneal stroma and even starting to track along the fibrin here. So it's trying to keep itself together. And then we've got our iris tips leaflets here coming out and prolapsing here, a little bit of fibrin on top. There's a little bit of a pre-iridal fibrovascular membrane here on top, and the spindle cells and blood vessels along here. Just trying to keep everything together. That said, not much of a uveitis going on. I believe the lens was fairly okay character-wise. Retina looked all right. And then again, here's our optic nerve with kind of an artifactual appearance here of looking like it's in the sclera. And if we look at what's going on back here in the sclera is, let's see if we can. So we've got a little bit more normal scleral collagen here, and then it just gets very homogeneously pink and smudgy and loss of cellular detail here. So this is cautery artifact. And sometimes when they use cautery in the back of the globe, it causes this like inward bulging of the optic nerve and optic nerve head. And so that's what was causing that appearance grossly, was the cautery artifact. And then I just have a quick second slide here. Again, a little bit more of the cautery artifact at the back.
You can actually see the collapsed meninges there, I think, right?
Yeah.
It's like if the optic nerve was a banana.
Yeah.
If the optic nerve was a banana and you hit it with some cautery and it just floop, it just squeezes
Call
out.
it a toothpaste effect.
Toothpaste.
Like you press the optic nerve and it squeezes out of the meninges inwards. Yeah, so that can happen with laser, and it can happen also with, if you clamp the back, if you clamp the optic nerve, either intra or post surgical. So
A magnifying glass with the sun.
yeah, exactly.
I do have a question that goes
Yeah.
back to sort of basic physiology of the cornea. I understand like how the epithelial structures or desmosomes, desmosomes, blah blah blah, for keeping it together. What is it that locks the collagen fibrils within the corneal stroma together?
Within the corneal stroma?
Yeah, that actually gets disrupted when we have keratomalacia.
That's a good question. The arrangement of the cornea is very interesting. So you have to imagine it goes like plates, multiple plates in collagens and different types of collagens in different orientations. So if you imagine like multiple plates, and not only they are multiple, but they have a little bit different angles as they go down, right? So that creates enough spaces that the light can pass without being bent. That's the main thing, right? And there are fibers that run perpendicular to those plates that are of different types of more delicate extracellular matrix, like fibrillin. Oh man, I'm blanking on the types of fibers, but they're not the thick collagenous fibers. And I think the overall, when you lose that overall morphology, the whole architecture just gives up. But
There's not just one thing that's targeted in there.
Is it simply
It's
that
just everything.
the types of collagen and then being relatively dehydrated? And then when
That's
you
true too.
can no longer keep your cornea dehydrated, then you lose that ordered structure?
There's that for edema, but I think there's the collagenylysis. The idea is that enzymes, either from neutrophils or from bacteria, will destroy the collagen chains basically, and that extracellular matrix dissolves. That's the main process. Because with edema, there's a chance of recovery, right? If the endophilic gets back working, you take the water out and the structure goes back to normal. So I think that's the main difference between edema and collagenylysis. With lysis, you have destruction of the collagen architecture. The edema is just added liquid in between the lamellar and expansion of the stroma.
So the edema could increase space, increase access to those structures for the enzymatic activity of the bacteria or the.
Good question. I think that's
neutrophils.
possible.
That's interesting. Okay. So I'm just thinking, like, how would you stop that? Yeah,
Well,
Q2 serum and then a whole list of other meds.
but that's exactly what you're just inactivating enzymes, right?
Basically, yeah. And that's the scary part of it. And that's
why
we're glad
steroids
humans, we don't have that in human medicine, right? Or in human nature. Our corneas don't melt like dogs, which will be panic-inducing situation, right? You scratch your eye one day in the morning, you wake up with a hole in your eye. When that happens in humans, it's very rare, and it's usually peripheral, like in the limbus, and they tend to be small. But it can happen super fast. Progression can be hours to, a day.
And that's what was striking, and that's why I was wondering, like, what.
Mhm.
Sorry to just derail the
No,
conversation.
no.
It was interesting.
Great conversation. Just a couple minor things to finish up real quick here. This is the other half of the globe. I submitted both halves since I kind of split the optic nerve head. But we were noticing a little bit that there's quite a concentration of degenerate neutrophils and a little bit of necrosis deep in the corneal stroma here. And so we were concerned that maybe there was an abscess, a deep stromal abscess that might have also been contributing to the corneal disease, with it being concentrated so deep in the corneal stroma. And I think the other thing that I rolled over as we were talking is that there is expansion of this suprachoroidal space here by a clear space, which is basically edema and a little bit of hemorrhage. And we can see that in cases where there's a sudden loss of intraocular pressure in the eye, so like rupture. We can see this if the globe is ruptured after surgery too. So we take it kind of all in context, and you got to make sure that you can also see this a little bit with a processing artifact. So just kind of take the picture all together in context. So this was, again, marked suppurative keratitis, maybe with a deep stromal abscess with some vascularization, the perforation with the iris prolapse, consistent with the ruptured descemetocele, some membrane formation, and there was a tiny bit of lymphoplasmacytic inflammation in the third eyelid as well. So just a good case of a ruptured descemetocele.
Quick question for those online. Can you guys hear our discussion in the background? I'm just curious if it's clear or not. Just type out there. Not really. Yes, mostly.
Mixed messages.
It's a bit quiet.
A bit quiet.
Somewhat. Okay, good. We'll try to come closer to the microphone.
We need to get microphones installed all around.
Yeah, we need to update our rig here and have some room-wide microphones.
Okay, I'm Megan, and I've got 2 cases for you today. All right. Our first case is a 14-year-old spayed female domestic medium hair cat. They describe buthalmus and exophthalmos, keratitis with suspect hyphema but unable to see inside the eye. CT scan showed diffuse iris and choroidal mass effect with possible scleral distortion, dark scleral mass in ventromedial portion of the globe. They also identified 2 pulmonary nodules on the CT scan. So here is our gross exam. We have our cornea up here, and we have pretty extensive destruction of the uveal tract. Some of the choroid is still looking normal back here, but the rest of it is basically expanded and effaced by a brown to tan mass, which is also breaking right through the sclera here and extending into the episcleral/orbital tissues and looking like a grossly incomplete edge from what we see here at least. There's also some retinal detachment. This is most likely some retina here, kind of grouped around the optic nerve head. And when it looks like this, kind of all folded on itself and is no longer really attached at ora serrata or ora ciliaris retinae, we think that this is going to be a torn retina. So if you see this on gross, think about retinal tear. But we'll take a look at this case. Maybe we'll just stay here. We'll see if that works. Probably not. All right. It's a big eye. I feel like I should follow suit and put my cornea on the left. Gillian is exulting over there. So here's cornea on the left, and we have this really expanded uvea, which now looks purple on histology.
Focus better.
Oh, I could try to
Yeah,
focus. I thought you said glorious.
Oh, no. No. I mean, it is glorious.
the leftwards cornea is. But anyway, focus would be nice. So yes, so we have a anterior uveal mass that now looks very purple, where although there is still some pigment visible even from subgross. We can see that it's mostly in the anterior uvea on this side, but kind of in the peripheral choroid. And then over here we have some dropout from sampling artifact, but we can still see a really excellent area where it is breaking through the sclera and into the orbital tissue like we saw on gross. Let's see, I'm gonna have to flip it this way to make cornea go on left, I think. All right, so we do have some corneal changes here, but I'm not going to focus on that for this case. I'm going to focus on the elephant in the room. So let's take a closer look at this mass. And these cells are quite pleomorphic, you can see, and they can be in these cases. It looks pretty scary. So we have frequent multinucleate cells. We have really big kind of owl eyes, quote unquote, nuclei with very distinct nucleoli and coarsely clumped vesiculate chromatin. And a lot of these cells just have straight eosinophilic cytoplasm, but many of them also have a faint to maybe moderate cytoplasmic melanin pigment. Yeah, just sort of giving you a brief overview of some of this high degree of pleomorphism. We may be picking out some mitotic figures here and there as we go. So there's a fair number of mitotic figures in this case as well. What I'm looking for, and should have dotted originally, look at these kerymegalic cells, is, let's see if I can find one that I like, just for fun. This one isn't bad, maybe. It could be better. So sometimes you'll see nuclei that have big sort of pink bubbles in the middle. There are probably better ones about. If you're really familiar with looking at cells and if you're scouring cases for viral inclusions, things like that may catch your eye. However, note that in cases like this where we have really big cells, that have really floppy cytoplasm, sometimes that cytoplasm will invaginate into the nucleus, and then you get these nuclear pseudo-inclusions. So these cases with high pleomorphism like this, you'll see some pseudo-inclusions here and there, just so that you know what you're looking at if you see it. And then I dropped in here because we have this fun atypical mitotic figure. It's basically like X marks the spot, showing its stereotype, as Leandro might say. This is a feline diffuse iris melanoma. Sometimes it's good to show the classics. Coplow assigns early to cases that are confined to the iris, just calls feline diffuse iris melanoma to cases that are confined to the anterior uvea. And then we call extensive feline diffuse iris melanoma when there's extension into the choroid and or the sclera, as in this case. So this was an extensive feline diffuse iris melanoma. Basically, the extensive variants have a relatively worse prognosis. Let's drop in on one field in particular and just be there while I'm talking, actually. And then there's a paper out that has 3 prognostic indicators for histologic evaluation of these tumors, and those are also very good to know. So one is 7 mitotic figures or greater. Another is, yeah, look at that. Oh, thank you, pseudo-inclusions. Maybe next to it. So one is 7 mitotic figures in 10 high power fields or more. Another is tumor necrosis, which is also a negative prognostic feature. And then extrascleral, specifically extrascleral, or choroidal extension. All those are associated with worse prognosis. They don't like stack on one another. Basically, if you see one or more of those, there's a relatively worse prognosis. Feline diffuse iris melanomas actually seem to have a relatively low metastatic risk as far as these things are concerned, although publications can vary quite a bit in what they report. However, some of them do metastasize. They have some degree of metastatic potential, and these are the types of cases that we're a little bit more worried about, particularly in this case where they found some pulmonary nodules on CT. Of course, those pulmonary nodules may be completely unrelated to this tumor. You don't know until you look at them on a biopsy or something like that. But that's feline diffuse iris melanoma. Sometimes it's good to see the classics. There we go. If there aren't any other questions, we'll do this case. Whoops, we won't make it big. Okay, we'll make it big like that. All right, so our next case is a dog. 4-year, 3-month-old neutered male poodle mix. There is a history that I'll withhold for now. They saw that this right eye was blind, had secondary glaucoma, uveitis, and hyphema back in September of 2023. And then some more testing, which I'll withhold for now. Long story short, this eye became phthisical. Let's see, had historic retinal detachment, had historic pyogranulomatous chorioretinitis, which is currently not visible by the time of enucleation because of a cataract in the way. And basically, the owner requested surgical removal of this eye to eliminate the potential for intermittent painful issues over time. So phthisical eye with some history that I've withheld. So we have this eye, which is very small. You can
Megan,
see
before we
relative.
go down,
Oh yeah, go ahead.
Dr. D is asking if we know that if there's any liver disease on the other cat, the one with metastasis to the lungs.
We don't know, in short. Not that they reported, but
Okay.
I don't know if they just didn't report or if there isn't.
Didn't see it.
Yeah, not on the submission form, at least.
Sorry.
Good question. Yeah, liver metastasis is something that we're worried about with diffuse iris melanoma, as well as other forms of melanoma, really. So it's a good question, asking after the health of the liver. Okay, so phthisical eye, it's tiny relative to the ruler down here, you can see. It's very wrinkled, which is pretty characteristic of Phthisis. If you want to differentiate a microphthalmia from a Phthisis bulbi, checking for wrinkling of the collagenous tunic is helpful. Wrinkling is a Phthisis thing. There's all this sort of white tan tissue inside the eye, which is also kind of a Phthisis thing. You get intraocular fibrosis. It's basically chronic scarring of a globe, is what Phthisis bulbi is. It's hard to actually make out what the lens is doing at this stage. They also note that the eye, when cut, had a bit of quote-unquote glitter bomb material in the vitreal space. I love that term. It's just a fun term. But basically, it's hard to capture in a photo like this. When we cut into this eye, there was a lot of sparkly material in it, very sparkly, shiny. You gotta love that. So when it's sparkly and shiny like that, it usually indicates maybe some degree of cholesterol formation. And it's a thing that you can see in some types of cataract, but in this case, probably more likely due to the chronic hemorrhage and chronic breakdown of that hemorrhage inside the eye, glittery and sparkly. Chronic hemorrhage also supported by this kind of orangey cast, the tissue back here. So probably a lot of this oranginess is hematoidin. And there's probably hemosiderin in there as well. So that is the gross of this eye. Let's take a look. The optic nerve was submitted separately in this eye. My guess is it was kind of a challenge to remove it, but we don't need it anyway. But in case you wonder why, that's why. All right. Here's our cute little phthisical globe. You can see that there is still a lens capsule here, at least. So this is a really advanced cataract. There was probably liquefaction of the lens fibers, and either they artifactually ran out of the lens capsule when we sectioned it, or they were resorbed to some extent because this is a really just chronic and advanced cataract. You can see where the optic nerve is kind of coming into the eye here, at least. All of this pinkish tissue back here, which is fibrosis, and also something else shaking in the posterior chamber, which we'll take a look at closer in a hot second. I will put the cornea on the left. Gesundheit. I will not put, wait, no, I did put it on the left. We're good. Go full screen. Yes, that would be helpful. So again, here's our little lens capsule, but we're going to focus on the stuff in the posterior segment. So we do have this really dense fibrosis lining the epichoroidal surface and basically filling much of the vitreal / subretinal space. The retina is actually pretty hard to make out. This is probably part of it. It's pretty atrophied and maybe to some degree inflamed and thickened. And we have all of these clear acicular clefts from low magnification, even sharply demarcated. Acicular just means needle-shaped or needle-like, and this is characteristic of cholesterol clefts. So yes, indeed, there's a lot of cholesterol in this eye. Probably just chronic breakdown of cells, especially erythrocytes. And we can see that those cholesterol clefts are accompanied by a lot of macrophages, many of which are multinucleate giant cells. Very pretty. And there's also evidence of chronic blood breakdown products. So we do indeed have hemosiderin, some of this light brown, and probably hematoidin around somewhere. But hang on. See, what I'm really looking for is my favorite area. One moment here. It's right at the tip of this protrusion of retina. It should be. It would help if I marked it, but I didn't want to put a mark over top of anything. So here we go. So as we look around in the midst of this lipogranulomatous inflammation, we actually start to see some interesting little structures here. And this is my favorite one. So these are poorly staining oval-shaped structures. They tend to present exactly like this, as just empty walls. And this one is cute because it's a pair of these round structures that are connected by a broad base. So these are actually dead fungal yeasts, and there's a couple of them about. This is my favorite pair because it's like the couple in the Titanic movie going down together. It's so romantic. They're holding hands. All right, maybe that's a bit dark. I don't know.
That's my favorite part of the movie too.
Yeah, right. The really sad part where the couple, anyway. All right. Okay, that aside, we have a broad-based budding pair, which is also helpful. And if you're wondering the history that I withheld on this patient did test blastomycosis positive by urine antigen and was treated to the point where successive urine antigen tests were negative. So basically a successfully treated blastomycosis case that had ocular manifestation. This eye was at one point ophthalmic and is now phthisical, is basically kind of a chronically treated eye. There are more of these dead fungal yeasts as you walk around. We probably don't necessarily have a great ability to decide if all the fungal yeasts, maybe that one, debatable, are dead or not, but generally speaking, characteristics of viable yeasts are that you can still make out nucleus or cell body inside those cell walls, and characteristics that are more suggestive of a non-viable yeast are just empty cell walls like that, and or a sort of shrunken and hyper-eosinophilic contents in those walls, maybe like a tiny bit of necrotic debris inside some of these. So at least I didn't see any that looked histologically like viable yeast. They look mostly dead where you find them here and there. So long story short, this is Gesundheit. This is what we refer to as a spent fungal disease. You could also refer to it as a treated fungal disease. And it's fairly characteristic of not necessarily just blasto, a variety of fungal etiologies, but treated fungal etiologies. You especially tend to get this very dense, especially epichoroidal fibrosis. Certainly you get intraocular fibrosis with Phthisis bulbi in any case, but the fact that it's kind of more posteriorly oriented in this case is interesting. You often get chronic hemorrhage in cases of treated fungal disease. And then, of course, finding the non-viable yeast is very helpful as well. And then definitely having the history is also helpful to tell you what's going on. And it's worth pointing out that based on this case presentation, if you see a case like this without the history of previous fungal infection, where there's this dense epichoroidal fibrosis, chronic hemorrhage, maybe granulomatous or lipogranulomatous inflammation in the retina and or choroid and or intraocular fibrosis, it's worth querying about the past fungal testing status in this patient, in such a patient. So that's it, spent fungal.
Was there lens capsule rupture, or was it just a
Good question.
that you appreciated? I know it might be hard to tell.
Good question.
Can you repeat the question?
Oh, the question was whether there was lens capsule rupture that I appreciated. At least not that I appreciated initially. So we could take a quick
that would
scan
be
over
somewhat
it.
unexpected in a fungal ocular mycosis. I'm just curious.
It might be handy on a case like this to do a PAS stain just to be sure, because the capsule is pretty tortuous and folded. But yeah, at least not that I saw. Certainly when the lens fibers are gone to this extent, you do kind of wonder if they're gone because they were exposed at some point, and the capsule often looks kind of squiggly squaggly. But yeah, not that I appreciated in terms of rupture. Yeah. Cool. So is 9, so we'll switch to that. And that's it. If there's any other questions, otherwise, thanks for coming around.
Thanks, everyone. See you guys in a couple of weeks.
Should be a special moment.
Nope. I could have, though. It would have been cool to see those walls lighten up. Ah, good point.
I was just curious.
I do wonder,